conference တက်နေလို့
Okay. Okay, shall we start?
Yes.
Okay, maybe this is the last slide. Maybe in the last Friday, maybe. Yes. So this slide shows the antiviral is different according to the slice. The upper slice is tend to show the reduced antiviral because of the characteristic of the morphology. Okay, I will explain in the next slide. But this one, this is just a line from the center of the shaft and the center of the femoral head. So, yes, so naturally, in the most case, this line pass just a little bit posterior from the center of the femoral neck. So, what interesting, this will be a, see, if the slice going down, it's come to the lower end of the femoral neck. But the middle and the upper, it pass posterior. So you can easily understand showing this slide, just actual slice of the femoral neck. The cross section of the femoral neck is not oval, but something like triangular shape. Its lateral posterior wall is vertical, and anterior wall is oblique. So, if we see the fluoroscope, we will see like this view. So, in this slice, in this view, the lateral view of professor is coming. So I will show you again. This is just the center of the femoral neck. This line is from shaft center to the head center. It's passed slightly posterior to the center of the femoral neck. But if slice is going down, it comes center of the femoral neck. So in other words, the bottom of femoral neck is not center of the femoral neck. It's slightly posterior. So it is quite natural. If we insert a lag screw from the shaft of the femur to the femoral head center, it is naturally passes posterior in the femoral neck. So, but don't worry. It's just look, it's passing the posterior side in the neck, but it must pass the bottom of the femoral neck. Okay, Chandra, do you understand?
Professor, yes.
So you should remember the cross section of the femoral neck is triangular. The posterior is vertical. The superior is horizontal. The anterior is oblique. Just rectangular triangle. So, in this view, in the lateral view, so your target in the femoral head, femoral neck is, wait a minute, it's just posterior third is the bottom of femoral neck. In other words, this is close to the carca femorale. So never go to the center of the neck. Otherwise, the pin or screw may go anterior into the head. If you want to insert this screw at the center of the femoral head, you should aim posterior third in the femoral neck. Again, the femoral neck shape is like this, not oval. So this bottom on femoral neck is approximately posterior third of the total width of the femoral neck. So I measured the morphology of the femoral head using a 3D CT. This is the femoral neck axis. No, femoral shaft axis. Femoral axis is just the center line as just below the minor trochanter and 5 centimeters below the trochanter, minor trochanter, and draw the line between the center of these points. Then to slice is rotate around this femoral axis and come to the femoral neck center. And then femoral neck head center and the femoral neck center is this line is the femoral neck axis. So this angle is neck shaft angle. I measured the 100 hip in 50 Japanese patients. The average was 126 degrees in average. Maybe this is smaller than the previous report from Western countries, but maybe in Asian countries, so especially in Japan or Korea or China, neck shaft angle is smaller than the Western countries. So currently, for example, gamma nail is the most popular angle is 125. The original one was 135. That was the original gamma nail. And DHS is well. Originally, DHS is from 135, 140, 145. But it was too steep for the Japanese patients. So currently, we can use the smaller angle nail or plate. But my DSCS, dry screw, it has still 135. But actually, so due to the round shape of the plate, you can adjust if you insert the guide wire, the screw, around 130 or 125. So it can be adjusted due to the shape of the side plate in the DSCS. But anyway, basically, this device for the Asian people, this shaft must be set between 125 to 130. So many paper from Japan or other Asian countries, but average neck shaft angle was mostly between the 125 to 130. So this is the characteristic of the Asian people morphology. So as I said, dual SC screw DSCS is on the 135. So screw direction is a little bit steep compared to the femoral neck axis. So again, this is a thread impingement. So sometimes this thread impinge to the femoral neck fracture. So if this thread come to the fracture line, afterward, the sliding never occur. So this thread should be shortened. So I measured the head length. Head length means this is a subcapital line, just below the femoral head, and draw the line parallel to the femoral neck axis. This is the lower. Lower is just next to the cardiac femoral. So this is the upper one. Upper axis means just below the superior cortex. So I measured the femoral head length in the middle length, lower length, and upper length. So the upper one was around 225 millimeter, and middle one, sorry, in Japanese, this is the middle one, is around 3 centimeter. The lower one was again 25 millimeter. So to avoid the screw thread impingement, the 2 centimeter thread length is too big, too long. Because if we insert the screw here, it is very, very important to achieve the 3-point fixation for the CCHS and even the DSCS. This position is very important. If we insert screw along with this line, this length should be the 25 millimeter. But if the thread is 20 millimeter and insert 5 millimeter from this cortex, subchondral cortex, so this length is already 25. There is virtually no space for the sliding. And in the very small frame patient, the thread is already across this subcapital line. So it is a very, very impressive result. Even the center the thread is, if the thread is 20 millimeter and 5 millimeter from the subcandular bone of the femoral head, that equals 5 millimeter, 30 millimeter. No, 25 millimeter. 20 millimeter plus 5 millimeter equal 25 millimeter. There is only the 5 millimeter to slide. So in the future, screw thread should be shortened. But shortened thread means the improper fixation, insufficient fixation of the femoral head, especially in the elderly patient that has osteoporosis. So it is quite a serious problem, difficult problem to solve. Maybe I will talk later about the new devices. So in this device, this screw thread has been shortened. Anyway, the lower one is again like this. In summary, the distance is in average like this. Of course, this patient includes the male patient that has a bigger brain. So some very small Japanese patient has the very, very small femoral head length. That can cause the mechanical trouble of the femoral neck fracture after the internal fixation. So, this is a new device. New device shorten the thread from the 20 millimeter to the 15 millimeter. So this is a very good point, because please look this thread, the width of the thread. The tip, at the tip, the thread is very thin, but base, near the base, the thread, the width getting thicker and getting thicker. This means if we insert this screw in the bone around the screw thread can be compressed, just like the blade impact into the femoral head bone. So after that, the bone around the blade can be compressed. That acts very beneficial for the screw fixation. This theory is the same. This step variable the width screw can increase the bone strength or fixation strength. In addition, this is a stem of the screw is tapering. The stem is also tapering. It can also act as a blade, so compress and the bone around the screw. So thread and the shape of the screw can improve the fixation even in the very short thread. Okay, so this is another device, a new device. So in average, the distance from subcapital line to the thread end, and in the upper one is around 10 millimeter, and upper posterior is around again around 10 millimeter, and this third one is around 11 millimeter. So it acts very, very, very well. So this is another topic. So extra osseous insertion of the screw is sometimes difficult to identify intraoperation. Because in this anterior view and the lateral view, so it looks this bone inserted within the bone. But actually, for example, so superior screw and posterior screw can penetrate the bone cortex, and some part of screw can be exposed. Even by biplanar anterior, posterior, and lateral view, on the lateral view and the AP view, two screws are correctly inserted within the bone. But actually, it was the extraskeletal insertion. Why? Again, the cross-section of the femoral neck is not oval, not oval. So if the neck is this shape, oval shape, the second screw can be here. So superior and posterior. So many surgeons try to insert this one as posterior as possible to just touch to the posterior cortex. This screw can act also as the 3-point theory in the sitting position. In the standing position, the load come like this direction, but in the sitting, the load come like this from the anterior. So this pin can stabilize by the posterior cortex for resist the anterior loading force from the anterior. But some surgeons recommend to the reverse insertion. The first thing is the bottom of femoral neck. And the second one is anterior superior. They say so if we insert a screw or pin like this, so this distance, maximum distance of two screw is the longer than the former version of insertion. The former one is distal one and the superior posterior one. But again, the cross section is like this, just like the triangle, the rectangular triangle. So posterior is vertical, and superior is horizontal, and anterior is oblique, like this. So, I'm sorry. I measured the distance, the width of this femoral neck, and solely this length, and this length is 21 or 22 millimeter. And anterior offset was around 40 millimeter, and the posterior offset is just 5 millimeter. Oh no, just 7 millimeter. I'm sorry. So if we insert the screw and distal and superior anterior, so the length can be maximum. Around this angle is around 27 degrees, and this length it should be the 20, maybe 20. Oh, sorry, it's not clear. Maybe 24 millimeter. So it is longer than the width, anterior posterior width, and the superior inferior width. This is the longest distance, so it is reasonable to insert this one, and the first one is here, and the second one is anterior and superior. But if we insert here and here to insert the pin as posterior as possible to touch the posterior cortex. So in this situation, if this second pin is inserted outside of the bone, but this is an AP view from anterior and posterior view. This pin is yes, inferior from the anterior superior cortex of the femoral neck. And in the lateral view like this, it is also shown as the intraosseous insertion. But actually, if the surgeon insert the second screw here, so we cannot recognize the extraosseous insertion using the normal biplane fluoroscope. But it sometimes occurs again. The surgeon tends to insert the second pin as superior as possible, as posterior as possible. So it is not rare. But I don't know. It is bad things or good things, because again, so I showed this previous one. But even this screw can insert it in the femoral head again. So it can act as a stabilizer of the femoral head. So it may act very well, even if it is inserted outside of the bone. So this is the profit or advantage or disadvantage, I don't know. But it is better to avoid this like this insertion in the outside bone insertion. We should be avoided. So I have not enough time. So Anyway, so to avoid this, I recommend to observe the insertion position of the second screw. So you should see the neck continuously from here and AP to the lateral, or at least you should make sure on the true lateral view if this screw is inserted properly or not. So AP lateral and true lateral, at least a 3 view should be better to recognize to avoid this kind